You're tuned in to RX Radio.
Ladies and gentlemen, welcome back to RX Radio. I woke up this morning. My blood pressure was pretty high. I'm working on it between the caffeine and the nicotine. But I'm sure frustration is not great for high blood pressure. I sat down here. I did an episode probably 2 months ago now. That I got some really good feedback on. I talked a lot about shoulder function and kind of tried to tie together a lot of loose ends that were just in my brain. And honestly, it was a very selfishly motivated episode. There were just a lot of things that I talk about this stuff often. I do it on the internet. I do it in person. I work with a lot of people that have, thankfully, a greater understanding of this stuff than I do. I work with a lot of people that have much less understanding of this stuff that I do, and everyone in between. And I was able to kind of just sit down and just let my brain bleed into the internet and talk about a lot of stuff that tied together shoulder mechanics, shoulder function, just movement in general for me in my brain. And then the reason that's so selfish is because now I get to send that to people when they ask me questions. I get questions about this stuff a lot. And I think it's really good, especially for trainers, therapists, and practitioners to have this this base understanding of function through certain regions of the body. And it becomes a really helpful building block in terms of understanding progression, assessment, meeting clients where they're at, and understanding where they need to go. And that's kind of the crux of being a good trainer to me, is understanding that baseline and then being able to bring people to it. So I got a lot of really good feedback on that episode. I got a handful of messages, but the one that stood out to me, I want to shout out Michael Liu from Brisbane, Australia. Reached out, sent a really, really nice message saying how much he appreciated it and was hoping for more content like this in the future. I'm like, sick. Yeah, I like that. I'll definitely do that. Because again, I hope that you guys find value in this. I'm never going to listen to myself talk on the internet again. It makes me sick. But this is also very selfishly helpful for me to get this stuff out there in an organized way. And I'm not saying it's organized, but in a way that's more organized than how it floats around, at least on the internet and, in pieces of content you guys have probably consumed from us before, and even in my brain most times. So I want to sit down and kind of do another one of these for a different body region, which I did this morning in the past, circling back to my high blood pressure. And something that cannot be good for that, aside from the nicotine and, the trying to murder myself with barbells, I forgot to record the fucking audio. So what we're going to do is we're going to record this a second time. You guys get take two. I would like to say I hope this is better, but I'm okay being frustrated with other people. No, I'm not. But I can tolerate that because a lot of times I expect it. Being frustrated with myself is the worst because now I just want to fight myself and I want to break my laptop. But I'm not going to do that. Not right now, at least. But if you've been listening for a minute, you know that this is nothing new. We're probably knocking on the door of 600 episodes. This has to be close to the 100th time I've recorded a podcast and something went wrong. We couldn't release it. So here we are again. You guys get version number 2 with the more agitated version of me. All that being said, thank you for being here. I appreciate you guys tuning in. And I am going to dive into kind of some principles around assessment, baseline, biomechanical understanding, and realistically just the way that I think of building a progression for a certain client, no matter what level that they're at. And hopefully this makes it a little bit easier for you guys to understand really what we should be striving for and how we can get there in terms of assessing a client, making it really simple, making it really actionable, and just kind of reducing some of the clutter and some of the noise around a lot of the stuff that's going around on the internet. I'm sure all of you know that things come different things kind of pop up more and more often on the internet, because someone does something different and they find a use for it, and in reality it's very limited. There's a very limited use for these things that are flashy, and this kind of just helps you cut through the noise. This, hopefully, depending on how frustrated I get and how coherent I could be the second time through this, I'll try and do that and relate it more so towards lower body mechanics, the way I think of assessment, and the way that I think we should be really thinking of exercise programming on the whole, whether we're trying to get someone out of pain, whether we're rehabbing them from an injury, or whether it's a high level performer that realistically we're trying to get them to be better at their job, whether it's a professional athlete or someone that's in strength sports. So that is where we will take this today. That's where I plan to take this today. And I can see visually on the screen that my audio is working. So this should make its way to your ears, which part of me apologizes for that. Part of me still wants to break my laptop. So fuck my blood pressure. Let's dive in. So like I was saying, a few months ago, I started to talk about shoulder mechanics and just realistically the way that things have to happen for us to be executing on them to a sufficient level. And I like that statement, but I think the way that we can build this into more of a principles-based approach is understanding that there is a gold standard baseline of function, right? And that's in every body region, and that is in the body as a whole, right? Things, yes, they happen in isolation in the body, but nothing really, as we go through day-to-day life, is happening in isolation. So that's kind of where we'll start. This is understanding what's going on with the client that's in front of you, right? And that, to me, always starts with a very detailed history and intake, right? People have injuries, things happen, and there's always going to be some sort of level of compensation around any sort of injury that happens in the body. Like a kind of a quick example of just an automatic thought process I have is someone sprains their ankle. I've worked with people that have sprained their ankles plenty of times over my career. And then very short term, the first thing they'll say is like, hey, what can I do to help this? And realistically, with tissue damage, with structural damage, there's not much you can do right away in terms of fixing the structure, right? There's a very real healing process that's going to take time, and it's going to be something that there's maybe things that we can do that will be moderately helpful, that will help them. But the healing process just kind of has to take place at the rate that it's going to take place. So the advice that I give someone that comes to me very short duration after an injury like that is that, okay, well, there's not much we can do to help your ankle right now, but I can guarantee you that you're walking funny and you're going to continue to walk funny until there's at least a tissue capacity in that ankle that's going to allow you to have more proper foot mechanics, leg and hip mechanics while you're walking. In that period of time, there's going to be a very repetitive stressor that is a compensatory pattern that we could start to proactively do things that will reduce the impact of that over time. And that comes back to the idea of taking an injury history on someone. When I have a client come in, I want to know every single injury that they've ever had. And say, we'll focus more on the lower body as we get into this today. But if someone comes in to you and they say that they have knee pain, okay, they have knee pain. That's an understanding. But if we can understand other injuries or other compensations that they may have formed in the past around old injuries, that helps us understand more deeply what's going on at the knee. Because knee pain or pain in general, pain is more so a symptom, right? It's not necessarily an injury, okay? And there are cases which, in a very acute scenario, someone gets hit in the knee, like a football player takes a lateral blow in the knee. They don't have an ACL, MCL, medial meniscus. There's some muscle damage, joint capsule damage. Yeah, all of these things are possible and probable in cases. Yeah, that's an injury, right? And it kind of goes back to what I said with the ankle sprain, is that if someone has an injury like that, there's not much we can do to heal to help the tissue healing process right away. But on the other side of that, if we're talking pain, a lot of times pain is just a symptom of a level of dysfunction, right? It's not necessarily the issue that they're dealing with. It's a symptom of the issue. So even though someone's having pain, there's the way that I look at pain is that there's a pain threshold. And if you guys are watching this right now, if you're on YouTube, sick, you can see me. If not, go on YouTube so you can. I'm holding my hand up as a threshold level, right? So if this is pain threshold here, and we go above that, we're in pain. Below that, we're not in pain. I'll give you an example for me, is that I have an area of structural damage in my right shoulder. I have a torn labrum on my right side that I've never gotten repaired. My left side, relatively healthy. It doesn't bother me. So in terms of the pain threshold, there's on the right side, I'm always going to be closer to, or in my case, even above that threshold, where I'm actually in pain or feeling sensations in that area. But there's always going to be something that leads to that pain, right? And a shoulder labrum, yes, that's a pretty direct correlation. But if we're talking just generally, someone that experiences knee pain, maybe it gets worse the longer they walk, or they feel it when they're squatting, or when they're playing the sport that they're playing. There is something that's getting them closer and closer to this pain threshold, that eventually they'll pass that threshold and they'll get into the point where they are experiencing pain. But just because they've passed that threshold, it doesn't mean that that's the issue. There's another thing in all of this, right? Is the x-axis of this graph is time, right? There's a level of dysfunction, and with that dysfunction, there's going to be time that passes and repetition of whatever they're doing that gets them to this threshold and past this threshold, right? So the pain is really just a symptom of the dysfunction that has led them down this route, where now they have a trajectory towards pain. And the dysfunction is present before they feel pain. In something that is repetitive, or if it's compensatory, like say my shoulder, my left shoulder is relatively healthy. It's still somewhere on this map, on this pain threshold, on this chart, right? It's just much further from that pain threshold on any given day than my right shoulder is. So knowing that there's a structural difference in these two sides, that gives me the information that on my right side, I'm always closer to that pain threshold or above that pain threshold, because there's a structural difference in that side, right? So there is a level of dysfunction around that, and the dysfunction is on a structural level. I think a lot of people without injury, the dysfunction is not necessarily structural, it's more functional, right? It's functional in the sense that the compensation pattern that they have, that they've developed, that is probably subconscious, it's something that they don't realize that they're doing, that with repetition over time, it accumulates into an issue that now is causing them to be above that pain threshold, that they're experiencing pain. And if this is a subconscious compensation, what that means is that even if they get out of that pain threshold by addressing the symptom of the pain, a lot of people, when they think knee pain, like, okay, what can we do for your knee? Let's do, I don't know, TKEs. Let's roll your IT band. Things that are very knee-centric in focus. That's treating the symptom of the pain. That's no different than me taking a couple ibuprofen and then go hitting a squat session, right? There's still something that's contributing to that pain. There's that level of dysfunction that is contributing to the pain that is underlying there, right? That's going to be ongoing unless we address that level of dysfunction, the thing that is creating dysfunction that's leading to pain. So that's kind of one of the principles that I want to talk about as we go through this, is that as we're having people that are coming in with symptoms, whether you're a practitioner or a trainer, strength coach, there's something that's leading them on this trajectory independent of what they're feeling. So if we take a detailed injury history for that person, and we know that, okay, they had an ACL repair 4 years ago, maybe they got to a point in their rehab where a lot of times people forget the injury or the severity of the injury after the pain goes away, right? So they'll come in, they'll tell you, yeah, I had an ACL repair, but it's fine now. It's not an issue. And that may be very true to them, right? It may be sub-threshold, but still there's a level of dysfunction, and there's a compensation pattern that they've developed around that injury, where if we're talking ACL repair, how long was it before the surgery? Okay, they had the surgery. They were probably immobile for a certain amount of time, or non-weight bearing on that side for a certain amount of time. And then in that entire time, they've now learned a movement pattern that they subconsciously believe to be how they move now, that is creating a level of dysfunction that is contributing to the symptoms that they're actually having, right? And then even though they've gotten to a place through rehab where maybe they're not having any knee pain, or they have range of motion that suffices for them, they may not have the understanding that they're still on that dysfunction, or they still have that dysfunction that's predisposing them to be closer to that pain threshold over time. And that's something that the more structural these things are in nature, the more ongoing that care has to be, right? It's not like we're going to restore them to pre-injury status in their knee through their ACL in a rehab process. This is no longer an issue ever again. This is now something that they're always going to be predisposed to dysfunction. And dysfunction is a very general term, but really what I mean is a lack of biomechanical consistency through that area. It's going to contribute to the way that they're bearing weight, the musculature that they're loading, and realistically their symmetry over time. And that's a really easy way to look at this stuff. And that's kind of how I want to simplify assessment today, is that we'll talk about the crux or the principles around assessment that you should be looking for in order to understand that, okay, they've had this injury, they don't have pain, but there's something that's inhibiting them from performing at their best, or this is something that pops up every now and then, maybe when they're more fatigued or at higher volumes, higher intensities, is understanding that it's not that specific area that's an issue. It's the function, it's the integrated function of the whole system that's an issue. People that have knee pain, and then maybe later they'll come back and they have SI joint pain, or maybe it's shoulder pain on the contralateral side. It's these things are not connected, right? There's a link between all of these things, and they interplay with each other as we talk about things that are in a closed system, in terms of axial loading, in terms of the way that they're interacting with gravity, that are going to happen on an ongoing basis. So that's really where I want to take this. And really what we can boil this down to in terms of compensation is that there's an asymmetry in the way that someone's moving from side to side, which typically means, say they have knee pain, and that creates they're immobile for a period of time. And I'm not even talking ACL surgery. I'm talking, in most cases, again, independent to acute injury, like anatomical difference, like actual structural anatomical differences. Most things that we encounter in a gym setting, they're going to be more so a product of repetitive stress, of the way that someone is subconsciously moving, something they're not conscious of, that they're doing on a very repetitive basis. So really, the first line of defense here is building that conscious understanding of the way that they're moving. And to do that, we need to be able to make observations, and we need to understand that, okay, it's not necessarily that we need to know exactly what's going on or what's causing this. It's more so that we need to be able to interpret that there is a difference in the way that they're moving from the right side to the left side. And if we think of that, a lot of times what it manifests as is, very simply put, it's an overloading of certain tissues and an underloading of other tissues. And that's because of that subconscious movement pattern that's causing asymmetries. And we all have them, whether there's injury or not. And building some sort of conscious awareness around that. And once you find a pattern in this stuff, the idea is that that pattern is likely not going to change. It's probably very deeply ingrained. And that's the reason that they're having these issues. So once we can identify that, yes, we always want to check in. We always want to continually be assessing, and assessing not necessarily like on a table, whatever that looks like. In your brain, assessment is just watching someone move, understanding how they should be moving. And the way that I like to think of this is building a gold standard of movement quality. Right. And that's going to be something that's dictated by how we can be biomechanically sound in the way that we're moving through specific body regions, first in isolation, but then more so in integration. How we can start to understand how, we should be interacting through the core and the scapula and the shoulder, and the core and the pelvis and the knee and the foot, and working upstream and downstream in both ways, because none of this stuff in real life, none of it happens in isolation. And I'll give you a couple examples of kind of in a very real sense what assessment can look like and how it should start. Because yes, looking at passive range of motion, active range of motion, testing specific strength of muscles or movements, or looking at these things, yes, it all matters, and it's all information. But I think the key principle here is that you don't really need to understand the root cause of what's going on. But if you can interpret what you're seeing accurately and efficiently and take action based off of that, that's going to be the most effective way to assess someone. So there's a couple things that are going to lead towards this, right? There's just understanding what the gold standard of movement in each body region should look like. And that, if you guys listen to that episode that I did about 2 months ago now about the shoulder, I spent a lot more time talking about the core than I did the shoulder. And I started with the core because even now, as we're talking about, say, knee pain, foot pain, ankle pain, hip pain, that's the symptom that we're dealing with. But there's a reason that we're dealing with that. And that's, if we look at injury or repetitive stress, the way that this is going to manifest is when there's an area that is not equipped to deal with the stressor that it's encountering, right? And there's different ways that we can look at this. But a very real, I'll give you two very real examples that I've dealt with in the very recent past. Last month was out in Tampa working with a bunch of college football athletes that were preparing for the NFL Combine. And the one I'm thinking about in particular, I was working with him around some knee pain. And the way that people interpret pain and vocalize pain, it's vastly different from person to person. It depends on, again, the sensations that they're interpreting, their past, their perception of it, their importance on it, how much it's intervening or interfering with the level of function that they want to have. But if you've ever worked with an athlete, like a high level athlete, and even just like someone who cares a lot about their performance, you've probably noticed that all they really care about is performing the way that they want to perform. And these things only become an issue when they can't perform at the level that they're looking to perform at, right? So college football athletes, they're typically not very well versed in anatomy, physiology, strength training principles, things like this. So I'm working with this athlete and he's describing what he's feeling to me. And I'm listening, and I did an exam on him, and going through this, I had no idea what was going on. There was nothing structurally wrong with his knee. Okay, so that's a really good starting place, is understanding that, okay, if there's nothing structurally wrong here, then what we're dealing with is an issue in terms of functional mechanics around that area. And that can mean a ton of different things. But I went through the assessment. Okay, like I'm seeing like lack of stability on this side. All right. And he's telling me that, the issue is that he can't post on this leg and change directions, which is a very important part of his job as someone who is soon to be playing in the NFL. And I'm looking at him, I'm working with him, and I visually just look at his legs, and I can see that the leg that he's having an issue on is probably about, I'd say, no less than 4 inches smaller than the other leg. The other leg, perfectly fine. Like, no issues, like strong, coordinated. There's some stuff that could be cleaned up in terms of stability and balance, but not a major issue and no symptoms. The leg that he's having issues on, there's so much less musculature there. So a lot of times we start to dive into, okay, like in theory, it could be X, Y, and Z. It could be your ability to internally rotate isn't as good, so that, you're putting more stress on the knee on this side. But if we just look at what's in front of us, a lot of times, that's all that we need to be able to interpret and start to make a change. And as you start to make a change, things will become more clear to you. But the most potent starting place that you can have is where you see a marked difference between one side and the other, right? Like the reason that he was having pain, and this is something that became very clear as we started to train and started to work together, was simply that he didn't have the capacity through the musculature on that side to be able to deal with the forces that he was incurring because of how powerful and fast that he was. So if I look and I say, like, all right, nothing's pointing towards any clear direction in terms of what could be causing this, but I can visually see that this leg is a whole lot smaller than the other leg. That's the thing that I'm going to fix first, or that's the thing that I'm going to start this process in, is I need to get more muscle on this side. And talking to him, his intervention before this was, okay, like I can't post and change direction on this side. So all through college, they just put him on one side of the field. And this is pretty much how people deal with pain, discomfort, dysfunction on a regular basis. Is like, okay, if I have pain when I squat, I'm just not going to squat. And that's not fixing any issue. That's avoiding the symptom, right? I'm doing things to avoid the symptom. So what we started doing is we started doing, very long tempos, trying to put isolated tension on the musculature that was clearly smaller than the other side. And with that, we saw a lot of improvement on everything that was wrong, because the root of the issue wasn't necessarily the pain. It was that he just didn't have the capacity through that area to do the things that he was demanding of it. So, and I'll give another example, a little more kind of like everyday example, is that I had someone this past week come into my practice. She came to me because she had signed up to do 100-mile hike over 10 days, which sounds insane, but she couldn't currently run or hike because of knee pain that she was experiencing. And yes, everyone, I go through an assessment. I look at range of motion. I look at, stability through the hips, through the core, everything. But the first thing I noticed as she walked in is the side that she's having knee pain on. There's a crazy knee valgus on that side that I'm not seeing on the other side. And I don't know about you, but the way I've understood gravity to work is that it always pulls straight fucking down, right? So if we have a hip here and an ankle under that hip, but the knee is nowhere to be found, the knee is, 15 degrees inward of that, gravity doesn't give a fuck. It's going to pull straight down. And there's going to be an area that starts to take more of that stress relatively, and areas that should be taking more of that stress that are taking less of it. So an overloading of one area, underloading of another area, that is going to cause something to happen, right? There's going to be some sort of result from that in a system where we should be moving relatively symmetrically, right? So what I'm going to work on with her is getting her to maintain a more neutral position from the hip to the knee to the ankle, right? And this stuff becomes very apparent is I don't necessarily need to know exactly what's going on with the knee. And she actually came in with an MRI saying that there was nothing structurally wrong with the knee. So that makes my job really easy. It means that structurally nothing is inhibiting us from having progress. What I need to do is take her to that gold standard baseline of function that if I understand how we should be moving through specific areas of the body, that I can start to now identify, okay, there's areas, and this could be structurally, this could be physiologically, this could be tissue capacity, this could be range of motion. But if there's a discrepancy from one side to the other, the starting place is reducing that discrepancy. It doesn't have to be anything more than that. And you don't have to understand it any more deeply than that. But there should be some sort of superimposition of, okay, this is what I'm seeing visually. Okay, I can see there's a visual discrepancy from this side to this side. So that's where I'm going to start my intervention. And then with that, what you're also going to do is you're going to overlay subjective feedback into this, right? Like the football player I was working with, like one of the first things we did is yes, we did some stuff to stabilize the pelvis, and we'll get into kind of the what that gold standard of biomechanics is in just a minute. But as we got into things where we actually loaded the musculature, and I'm talking like, I don't know, this dude's like 6'2", like 200 pounds. He's not a small guy. I put two 40-pound dumbbells in his hands, and we did Bulgarian split squats with a quad bias with a 5-second eccentric, and not a big problem on the side that he didn't have issues with. When we got to the side that he was having knee pain on, he's shaking like a leaf, right? His quad's on fire. It's burning. And that's very valuable subjective feedback, is that subjectively, there's a difference in the same movement pattern on this side versus this side. And if we know nothing other than that, then our goal, it very simply can be that I want these two things to be equal, right? So we're going to work on this, and this is going to be our primary focus until these things are reasonably close. And then we're going to start to progress from there. We're going to make other changes from there. And in that time, because that doesn't happen immediately, right? You can, if you're effective at this and with lower grade issues, you can have a lot of an effect on these things. And even higher grade issues, you can have a lot of effect on these things within one session if you're accurate in the way that you assess and the way that you intervene with these things. But this is a thing that to actually correct these discrepancies, it does take time. And you're not just going to be doing bilaterally loaded split squats with a crazy tempo the entire time. You're going to be doing other movements that hopefully you have some sort of thought process or educated approach around that are going to give you more information. And the more information you have of what you're seeing visually, what you're seeing objectively, and what they're experiencing subjectively, that helps fine tune your approach. And it doesn't have to be any more complicated than I see a difference from right to left. I want those two things to be closer together. Okay. So that's kind of the underlying thought process that I want to lay out as we get through kind of the rest of this episode, talking a little bit more about the mechanics that we should be looking upon to build that gold standard of function through the lower body. I'm going to take a minute. This coffee was full. Actually, I had coffee before, but this coffee was full when I started the first one. And my blood pressure is so much higher now because of not just the frustration, but also the nicotine consumption and caffeine consumption in this time being. So give me a second. All right. So when we start talking assessment, yes, we want a very complete injury history, because none of this stuff happens in isolation. And even something that has recovered to a point where someone is sub-threshold in terms of pain doesn't necessarily mean that they are gold standard in terms of function. So that's the relationship that we should be trying to break apart, right? Is just because someone's not in pain doesn't mean that they have a high level of function. And really what we're trying to do is look for really easy, low-hanging fruit in terms of ways that we can interpret where their function might be lacking. And then we can start to make changes around those specific variables. And I guarantee that you're going to see a positive reflection in the correlation between their subjective sensations as we start to clear those things up. So number one being just, yes, injury history, but then visual appearance, right? Can I look at this person through the region that they're having issues and the contributing areas to that looks different? Is there a visual difference between these two areas? And then something else that through the lower body, I find to be very helpful information, because really what we're trying to find is asymmetries or discrepancies from side to side. And they become very apparent if you know what you're looking for. Something that I'll have people do right away is I work with people on a table. I am a chiropractor, but even if you're not, you can have them just lie down on the ground. I'll have them lie on the table, and I'll simply just look at their feet. I'll look at the position that they're in, because if someone comes in and one of their feet is just pulled out to the side and the other's sticking straight up in the air, that gives me really valuable information. The primary way that will create stability through the hips is through rotational stability, right? So if I'm looking at someone and they have a bias towards external rotation on one side and a bias towards a greater relative degree of internal rotation towards the other side, that's valuable information. Because what that's telling me is that the way that their body, their nervous system is subconsciously creating stability, or their perception around the positions that they're stable in, are very asymmetrical, right? And if you don't work with someone on a table, just have them lay down on a mat, tell them you're going to do a glute bridge, and just look at their feet as they're resting there. Because resting muscle tension it's a representation of a way that someone's nervous system is going to coordinate stability for them, right? And through the hips, through the shoulders, what we want freedom to move through both sides of that arc of rotation, right? We want to be able to start in a very neutral place and move through internal and external rotation. Now, as those positions bias one side or vary, we know that a muscle, if it's resting in a neutral length, kind of through its middle range of motion, it's going to have the highest capacity to produce force, right? There's a greater overlap of those sliding filaments. So there's more potential to create the cross bridge and create contractions through that area in kind of that middle range of movement. As we get more towards the lengthened side of that or the shortened side of that, there's going to be a decreased potential for force production. Okay. And that's really important, because now if we understand that someone has a bias towards rotation one way versus the other, then really what that's telling us is that neither side is in a great position to produce or resist force, because they're both starting from a disadvantaged position. And typically the way that the nervous system will create stability in an area where it doesn't necessarily perceive that the person has the ability to consciously control movement is it'll say, okay, we can't control the movement in this area. So what we're going to do is we're going to use muscle tone, muscle tension, resting muscle tension to create stability by shortening that muscle or contracting that muscle. So basically their body is telling us that there's a lack of stability moving into, if they're biasing external rotation, they're going to have a hard time stabilizing in internal rotation. If they're biasing internal rotation, they're going to have a hard time biasing or getting into and stabilizing external rotation on that side. That's really important information. And the thing is, we don't need to process it much further than that. All we need to be able to do is understand there is a difference in these two things, and there is a benefit in reducing that discrepancy from right to left. So understanding this is a really important part to knowing the way that we're going to be able to have meaningful intervention in the way someone's moving, just because we have that gold standard in mind of, okay, we should be able to rest in a neutral plane or a neutral degree of rotation on both sides. And if we're not doing that, then that is a level of dysfunction. that is going to have consequences, or it's going to have upstream and downstream implications in the way that we're moving, that is going to it's going to affect the sensation, the subconscious perception of how we're moving on a day-to-day basis. So that's the idea that I really want to drive home here, is that it's not necessarily about understanding exactly what's going on. It's about being able to understand that there is something different, and then having tools in your arsenal that you can start to intervene with these things. So as we look at that, now we can start to talk about building out that model of, this is my understanding of the gold standard of how I should be moving through each area, right? And that really starts with the core, because as we look at movement, there's going to be specific regions that have to be doing their job for other regions to be able to do what they're supposed to do effectively. And that always starts with the core. And core stability, neutral pelvis is where I spent a lot of the time, if you listen to the episode on shoulder mechanics, that's where that starts. And it's the same thing with the lower body. And I'll give a shout out here to, of course, one of my favorite clients, Taya. Taya is a very gifted athlete. She's very special in a lot of ways. But I've had this conversation with her for years now. And very recently she came to me and she asked me, what is a neutral pelvis? And a lot of times I kind of take it for granted that people would understand what that means. So let's start there in terms of what a neutral pelvis is, right? And this kind of comes back to that rotation through the hips, is that when I'm talking neutral, I'm talking a place where the muscles that attach to the pelvis are in a resting length that advantages them to the greatest degree all the way around, front to back, side to side, all the way. And what that ends up being is that ends up being aligning our structural components through the lumbar spine so that we have a neutral degree of pelvic tilt, so that we can equally advantage the muscles in the front, the back, inside, outside of the hip joint itself, everything that attaches to the pelvis. Now, as we look at the pelvis and how we're going to do this and how we're going to execute on this, because of the structure here, it's largely going to be through the sagittal plane, front to back. When we talk of the pelvis, yes, there are situations where people have kind of a hiked hip or there's a rotational component to it. Yes, and I understand that. But the reality of all of this is that we move through all three planes at the same time always, because that's the world that we live in. But when we're talking about equating for this in the pelvis, there's a reason that I want to talk about core bracing and the lumbar spine and pelvic tilt first. The reason for that is that if we look at the pelvis, we look at the rib cage, we look at the lumbar region, there's all of these things are different, yes. But one of these things is very different in the way that the lumbar spine, the structural component of stability, is all towards the back of our body, right? If we look at the rib cage, we have our spine in the back, yes. But then we have these bones that attach to it, our ribs, that wrap around to the front and attach to our sternum through cartilage. And they create a ton of thoracic stability. We don't really talk much. Yes, in a more advanced manner, we'll talk a little bit about thoracic positioning, but it's not often you hear people talk about thoracic stability. And the reason for that is those bones give us a ton of structural stability through that region, right? There's a lot of structure that makes it so that we don't have to use our muscles. We do, but we don't have to think about using our muscles to stabilize that region, right? And that's the difference here, right? The pelvis as well, we have our two ilia, and they have our sacrum in the middle, that's connected by ligaments, a lot of very strong ligaments. So it's a very structurally stable area. In our lumbar spine and through our core region here, our abdomen, the only structure we have is our lumbar spine, right? We have 5 bones oriented towards the back of our body, right? And the difference here is voluntary control. We have voluntary control of our musculature. We don't have voluntary control of our skeleton, right? Muscles move bones. So if we look at this, and we also understand that, I think textbook definition of a human center of mass is like 2 inches anterior to the L3 vertebra, give or take. I don't give a fuck. It doesn't matter. And there's going to be variance on that. Someone with more anterior mass, a bigger belly, that's going to be even further forward. Someone that's maybe more lean, that's going to be closer to that true place. But regardless of the deviation there, we can infer that is in front of our spine, right? So the difference here is that through our thoracic spine, through our pelvis, there doesn't necessarily have to be this voluntary control of position to create stability, because the bones are stable. There's a ton of stability there. In our lumbar spine, if we don't have voluntary control of that positioning, what we're going to try and do is we're going to try and find positions that are stable using the structure. So that means bringing that lumbar spine forward, creating lumbar extension, and that anterior tilt of the pelvis. The reason that becomes an issue is because now inherently what we're doing is we're shortening muscles on the back of the body through the abdomen, and we're lengthening muscles in the front of the body. So neither of these are fully advantaged in terms of force production to maintain the position that we're asking them to. We're fully dependent on the structure, right? Not fully, but we're more so disproportionately dependent on the structure of the spine for the stability through that region. Now, the issue there is that if we look at how tissues adapt, muscles and bones both adapt differently to stress, right? So if we think of a very simple example, biceps. If I go into the gym and I do 6-8 sets of bicep curls, there's going to be a point at the beginning of that workout where I have a greater capacity to manage stress and load through that musculature. And then I'll go through, I'll do my set. It'll start to burn. It'll get tired. It'll be a decreased capacity at the end of the set. I'll rest. I'll do another set, and it'll be that same trend, but each set will be a lower capacity to deal with that stress. Now, what I do is I go and I eat and I sleep and I recover, and my body breaks down that food and uses the hormones that I produce in my sleep to create a better capacity to deal with stress the next time I walk in the gym and I do bicep curls, right? My muscles grow, they repair, and now I have more functional tissue there to carry out that same movement of the bicep curl. So over time, session to session, week to week, month to month, year to year, my biceps get bigger, they get stronger. There's a positive adaptation. I'm adapting in a way that allows me to be more successful at producing force through the bicep. Cool, sick. That's the premise for strength training in general. Now, the way that we adapt through more structural tissues like bones and ligaments, and a caveat to this, a big portion of this process is inflammation, right? Inflammation is the signal through that area that tells your body something needs to change here. Now, if I do that through my lumbar spine, through my SI joint ligaments, what happens is I load them repeatedly over time. I get some inflammation there, and my body says, okay, we need to adapt. All right, so we're going to adapt to this area. And what happens, inflammation over time through ligaments, it causes the weakening of ligaments. Or in bone tissue, your body says, okay, there's a lot of stress to this area. We need to adapt. So we're going to pull calcium from the bloodstream, and we're going to lay down more bone here, right? So we have more bone there. And that's also a big premise of using exercise to promote greater bone density. But the issue becomes if we're doing that through our joints in a way that's not biomechanically consistent with the way that we load them, now that turns into calcium deposits in the joints, which is defined as degenerative arthritis, okay? Which is something that it happens over time. Yes, we get bone deposits, our joints get bigger, cool. When it becomes an issue is when there's a disproportionate amount of stress in certain areas, and that is accelerated in those areas. So if that's accelerating in the lumbar spine, then that becomes an issue because your body's trying to stabilize an area, which we need to have some variability and we need to be able to move. So the big thing kind of like in short here is that as we put force through muscles, there is a positive adaptation that they become better at dealing with that force. As we do it through joints and bones and inert structures, the adaptation becomes negative because our body's trying to prevent movement at a joint, which is meant to give us movement. And we decrease the capacity to move in that area over time. So all of that being said is that what we need to learn to do through core bracing and through controlling the degree of tilt in the pelvis is allow our spine to be in a place where it disperses forces in its biomechanically neutral position, which is those vertebrae stacked on top of each other. So a neutral pelvis means that our lumbar spine is aligned in its anatomical sense, right? So the lumbar spine, it is an extended curve. It's a lordotic curve, meaning it curves towards the front of our body. But the more we increase that, now what we're doing is we're taking more of that force that we're bearing axially, top down, and we're putting it into the structure, the bones and the joints, and less of it into the musculature. So we're encouraging a more negative adaptation through the bones than the positive adaptations of actually strengthening the core. So that's kind of buy into all of this, is we need to understand how to create favorable adaptations in creating pelvic stability so that not only it's something that's sustainable long-term, but also there's favorable adaptations that make this easier to execute on long-term, as opposed to kind of pigeonholing us into certain positions because we're losing range of motion through the joints of the spine. That being said, the other benefit, the more immediate benefit of this, is that if we can create a neutral position to the pelvis, now what it's doing is it's creating a trajectory downstream through the lower body that the muscles that attach to the pelvis are sitting in a neutral length, right? So they have a better capacity to produce force and absorb force and resist force in the way that we need them to walk upright as humans, but especially the way that we need them to if we want to perform in the gym or perform in athletics, right? If we have that anterior tilt, then what we're doing is essentially we're shortening the tissues on the front of the body or lengthening the tissues on the back of the body. And then with that, we're disadvantaging both of them to do the things that we're asking of them, especially in something like a hip hinge or something like a squat or a lunge pattern. I'm out of coffee. So the other side to that now is the greater capacity we have through the core musculature to stabilize the pelvis. That's going to allow us to be more effective in putting that tension now when we're moving and we're creating force exactly where we want it to be. Because if there's a deviation in pelvic position from the top down, what that means is that we're now, as say I'm doing a quad extension, right? I want my pelvis to be stable. I don't want any movement at the pelvis. So I can control the movement at the knee to allow that muscle to lengthen and shorten in a very controlled manner. If I'm not controlling the pelvis in this, then what's happening is I'm moving from both sides. So I'm creating a lesser capacity to produce force than I would be previously. Though this is like if you're trying to play tug of war, right? And if someone on one side runs forward as you pull backwards, then there's not going to be a net change in the length of that rope. Versus if you anchor one side and you can pull from that side, then you're pulling that towards you. There's going to be a net change in the rope between the two people, right? So that's what we're trying to do here is we're trying to create a net change in length, but we're getting less than that if there's movements on both sides here. So pelvic stability, neutral pelvis is going to be a position that we can get ourselves into where the lumbar spine is aligned in its anatomical sense, and we can prevent movement from the top down in the pelvis, right? That is top tier. If we can't do that, there's no point in doing anything past that because we're becoming ineffective at it, right? So that's the number one thing. And that's base level. If someone can't do that and you can teach them how to do that, you've made them better at everything that they can do using their lower body, using their upper body, anything they do when they're weight bearing. So that's, if we're talking that gold standard, that gold standard of function, that is it, is understanding core positioning, understanding how to deviate pelvic tilt as appropriate, and how to prevent movement from the top down in the pelvis. Okay. So that's where it starts. If you notice that someone can't do that, that's where the majority of your focus should be. Now, downstream from that, there's going to be things that we need to focus on in terms of creating a better understanding consciously of how people can do these. And that's going to be dictated by the arrangement of the joints. The way that our joints move is going to dictate that. And that's what I'm talking about with a biomechanical gold standard. And whenever we find deviation from that, simply all that we're going to do is we're going to work towards getting them to execute on that to a greater degree, and not just to a greater degree, but individually, unilaterally, to a greater capacity, or to a more symmetrical capacity. And what that starts to look like in the lower body is that the way that the joint moves in three-dimensional space, as we go into flexion at the hip, that is paired with a degree of external rotation and abduction. Okay. As we go into extension at the hip, that is paired with adduction and internal rotation. So even just knowing that, if we can put someone into a lunge position and we can see the way that they move and we can see they're having a hard time executing on any one of those things, that's the thing they need to get better at. And that is going to have a positive effect on whatever symptoms they're having in the lower body, just by getting them closer to being able to execute on the way that their joint wants to move in that position. And the reason they are having a hard time executing on that is probably because their body is stabilizing them in a position that they've been pigeonholed into, because they don't have the conscious awareness of how to stabilize in those positions. So if you're watching someone go through just a stationary lunge and you're seeing this crazy degree of adduction in that front hip, if you're seeing that they're having a hard time maintaining foot pressure, and I'll give you the cheat code to foot pressure. If their little toes coming off of the ground, then they're avoiding getting into external rotation. If their big toes coming off the ground, then they're avoiding getting into internal rotation at the hip. So look at their foot, look at the trajectory of their femur, and understand where they're missing out on that, whether it's conscious or subconscious. This sounds weird to say, but I'll touch people's feet. I don't give a fuck. If you're not executing on it, I'm going to put my finger on top of your big toe and I'm going to push it into the ground, say push here, right? Until they get that understanding that that's going to be the thing limiting their ability to rotate through the hip, is that the fact that they're escaping it downstream. So even if it limits their range of motion, I want them to maintain that closed system so that they're not moving from both ends, right? It's not that game of tug of war where both sides are moving. We're anchoring it from the foot and we're forcing them to move at the hip. And then the other side of that is look at their back leg as they're in a lunge. Are those toes drifting out away from the body? Are they rotating outwards? If so, okay, they're having a hard time maintaining internal rotation to the hip. So decrease the range of motion, use things like isometrics, use things like external support, anterior load, to put them in a position where now they can't escape internal rotation at the hip. And someone who has a crazy bias in this, there's going to be a greater ease executing on this on one side versus the other, right? And that's information that we want to see, is like, okay, this is harder for you to maintain this position on your right side versus your left. That means that we need to work on this on your right side, because you'll see, and I see it in every single person I've ever trained, if something's easier on one side than the other side, they're always going to start on the side that's easier for them. And they're probably going to go through it just fine. And they get halfway through the set on the side that's harder for them, and they're going to lose positions. The exercise is going to become less efficient, less effective on executing on that intention. So what we want to do then is we want to switch that. Is we're going to start on the side you're having a harder time on. And we're going to limit loads and volume and frequency based off of what you can see improvement there on. And we're not going to worry so much about it on the other side, because there's one side you're executing really well on. There's another side that you're executing very poorly. And that's no different than me saying, all right, you can't post on your left leg, so we're just going to put you on the right side of the field, and you're going to play your whole college career playing on the right side of the field. And we're never going to acknowledge the fact that you can't post on the left leg or do anything about that, is we're just going to allow you to do the thing that you can do, and we're just going to forget the thing that you can't. That's not how we fix these things, right? It's just identifying the things that are hard for them to execute on and then doubling down on that and not giving them a place to escape and saying intention around improving that thing. And that's all we really need to do in terms of execution. And in terms of what we should be looking for downstream on this is that, yes, at the hip, that's going to make up the majority of this, right? And the hip is a little bit different than the shoulder in the fact that shoulder, most of the things we do are open chain, right? Core, rib cage position, scapular stability, shoulder stability. That's going to have a large impact on how we're moving at the hand. At the foot, it's, yes, top down, working through the core, working through the musculature, the ability to stabilize through rotation of the hip. That's going to be very important. That's going to have a large impact on this. But because of the closed chain nature of us walking on our feet, there also needs to be some sort of a bottom up intention here, is that they've been striking the ground with their foot the same way every time they walk, always. So they probably have a very low capacity to change that from the bottom up. And that's going to make it very difficult if we only work top down. So understanding that, okay, we have that biomechanical gold standard of how we should be moving or what we should be striving for to get people to move through the hip. What does that look like through the foot and the lower leg? And simply put, what that looks like is that there should be a correlation or a connection between external rotation at the hip, so kind of that flexion, external rotation, abduction. And then as we're in those positions, we want to see tibial external rotation and supination at the foot. And as we internally rotate at the hip, we want to see tibial internal rotation and pronation at the foot. So once we understand these things and we understand that, okay, this is what I should be looking for at the core predominantly, but also how that should correlate to the way they're moving at the hip, the tibia, and the foot. Now that gives us a framework of, okay, yes, I understand these things should be happening. And that's the biomechanical gold standard that we're looking to create with this person. We don't necessarily need to know exactly what that looks like on that person. What we need to be able to understand is what's the discrepancy to execute on that from right side to left side. And if we can start to build a relationship of, okay, this is what it looks like on the right, this is what it looks like on the left, and then overlay that with the subjective component of, okay, this is what it feels like for them on the right, this is what it feels like for them on the left. And then we start to intervene in a way that encourages them to be more biomechanically consistent with the way that they're moving, top down, bottom up, then I guarantee you're going to see an improvement in the symptoms that they originally came to you with. And that's the idea here, is that you don't need to know exactly what's going on, but what you need to do is be able to visually interpret what you're seeing and then listen to what they're saying to you and then start to make changes towards that gold standard of this is what it should be on both sides. And there's a deviation one way on one side and compensatory deviation the other way on the other side. A lot of times it doesn't matter why they're having those things. And yes, you can dig into lifestyle factors, repetitive stressors, and things like that that are contributing. But to get the ball rolling, you just need to know that there is a difference. And if we can work back towards the middle on both of those things, then that's how you're going to be able to make the most effective intervention. I think that's all I have to say for right now. I appreciate you guys listening to this. I really wish the first time that I record this that it worked, but this one turned out not so bad. If you guys have more questions or you want to understand more about this stuff, Prescript Level 1 is your starting point. I guarantee you this is stuff that's going to make your training career so much easier if you can interpret this stuff. The faster you can see it, the faster you can pick up, and the faster you can intervene. And honestly, you'll see an improvement. You may not fix this stuff, but you'll see an improvement within 3 sets of the right corrective exercises if you can do this stuff accurately. I've been working with people in this capacity as a trainer for, I don't know, probably 16 years now. As a chiropractor, I'm coming up on a decade. And in my time in practice as a chiropractor, I have a spreadsheet of every single exercise, not just the exercise, but the circuit I've sent to every single person. It's ridiculous. There's so many sheets and there's so many rows and columns in this thing. But what I can tell you now being a decade into this, there's so little variance. There's so little variance in the exercises that you need to give people to be effective, right? I can think of, for upper body and lower body, 4 different exercises that are my starting point for the majority of people. And that doesn't matter if they're a professional athlete. It doesn't matter if they're trying to get out of knee pain, if they're post ACL. There's very small variation in what people need to be doing. And that's because there's very small variation in the human body. And there's always going to be fringe cases with acute injury or surgical intervention or anatomical deviation where people are just different, and you might have to make extra considerations around that. But the majority of this, it does not change. And I guarantee you that with very few exercises and very little time, you can make a positive impact on the way that someone is moving and the way that they're perceiving the way that they're moving. And it's very easy to do if you understand these things. So, Prescript level 1, it's not up for sale right now. If it's something you're interested in, go over to the website, www.pre-script.com. Drop your email on the wait list, and what we'll do is we'll send you an email with a discount code for the only available discount for the course when it goes live for sale, and you'll be the first to know. If you guys have more questions, if you like this, reach out to me. We'll talk about it. I'm happy to talk about this stuff. I might just refer you back to this podcast, but I appreciate you guys listening. Yeah, we'll do this again soon. Thanks, guys.